Hello, my name is Dr. Paul Finger, and today we're going to talk about basic ophthalmic plaque radiation therapy, a polar expedition. I say a polar expedition because we're going to be coming from the front of the eye to the back of the eye, and the eye is like a globe. So in 2014, I chaired the American Brachytherapy Society's efforts at a consensus for plaque brachytherapy for intraocular tumors. I assembled a group of 50 doctors from more than 10 countries, and what we decided was this was the essential equipment and personnel needed for ophthalmic plaque brachytherapy. You should have trained personnel. There should be an experienced radiation oncologist and medical physicist on your team. Basically, plaques come in different varieties. In the United States, they're mostly gold seeded I-125 plaques or palladium-103 plaques. In Europe, ruthenium-106 is more common, and in Russia they use strontium-90 as well. You need a transilluminator that helps you in surgery for locating the tumor. Indirect ophthalmoscopy is necessary to see through the pupil of the tumor, and B-scan ultrasound imaging is vital for making sure the plaque is in place and other things as well. So let's start at the top. Epicornial plaque brachytherapy. Here you see an eye that has already had surgery. The plaque is in place, and you can even see the amniotic membrane that is buffering the plaque from the cornea. The tumor is underneath. In this case, the tumor is right underneath this plaque. The gold shields everything going this way, and the radiation goes into the eye in that local area where the tumor is. This does not require intraocular surgery, so it's very safe relative to, say, a resection of the tissue. Sometimes the tumor involves the entire iris, so we put a plaque over the entire front of the eye, and in those cases you have to bring tissue over to sew it shut for the 7-day treatment. Afterwards, you open it up and everything goes back into place, and patients actually do quite well. The amniotic membrane technique I introduced in 2008 is graphically displayed here, where you have the plaque on the cornea and you slide the amnio membrane underneath the plaque. The plaque acts like a little bit of a clip on a clipboard and holds it in place. No sutures are required. And then you cover the entire plaque and amnio with a Gunderson flap. This is a more standard plaque. We've gone from the cornea, now we're going around the equator of the eye and slightly posterior to the equator. And standard plaques like this, with palladium seeds in this case, are sewn to the wall of the eye over the tumor. Plus there's a 2 to 3 millimeter surround beyond the tumor just to make sure we don't miss. And that's very standard. When you're putting it in, you'll notice that there were muscles that were pulled away. It's always important to discuss muscle surgery at the time of plaque insertion. Muscles are very radiation resistant, so sometimes we place them on tendons. Muscles have to be moved, and if you don't move muscles and they're in the way of putting your plaque in place, for the entire week they'll be pushing on the plaque and potentially displacing it. So it is my recommendation that if there's any doubt that the muscle is going to cause any type of pressure or displacement of the plaque, just move it away to some neutral place for the week and then put it back at the time of plaque removal. With that said, we looked at over 300 cases that were performed here at the New York Eye Cancer Center, and less than 2% of patients had any double vision, long-term double vision. About a third have some double vision for a month or two, but in terms of persistent double vision that required some intervention, it was less than 2%, and even only one patient out of the over 300 patients required surgery. Most of the patients just could have a little prism to relieve all their symptoms. So here we have a movie of a plaque in place, equatorial plaque in place over the tumor, and you'll see as it rotates around that the plaque covers the tumor and the radiation goes into the eye to cover the intraocular portion of the tumor. Unfortunately, unlike the movie, radiation keeps going, and other parts of the eye do get some radiation. But thankfully, radiation, at least the palladium radiation and other low energy sources, drop off very quickly. So most of the radiation is absorbed close to the tumor, in the tumor, and very little actually makes it to the opposite side of the eye, and even less makes it out of the eye. So it's really an ocular radiation. So let's go one step back. And this is a little bit more complicated and also very important. So back in the day, we used to use notch plaques, and notch plaques have a 4mm notch typically, which is actually inadequate to overcome the optic nerve sheath diameter. We all know that the optic nerve in the disc is somewhat less than 2 millimeters in size, but the optic nerve sheath behind the disc is 5 to 6 millimeters in size. And that is why we have this second circle around, just to show you where the optic nerve sheath is behind the eye. So in order to overcome the barrier or the obstruction of the optic nerve sheath, we needed to make a much larger opening in the plaque to allow the plaque to move beyond and completely encircle the tumor. I developed a thing called finger slotted plaque, where here's one of the first ones where it was 8 millimeters wide. Remember I said the optic nerve sheath was 5 to 6 millimeters. That gives us about 1 millimeter's breathing room on either side. And it needs also to have 10 millimeters beyond the apex of the slot to the edge so that the surgeon can get to the eyelets to sew it in place. Now this particular slot is quite large. The slots vary depending upon how much of the optic nerve needs to be overcome. So for example, here we have a melanoma that's completely covered the optic nerve. So we can't even see the optic nerve. So the slot has to be quite deep so that we can get all the way around and cover the entire tumor. And this was 2 years later when the tumor had regressed, and here we have the optic nerve uncovered from underneath it. This is a graphic display of those relationships between the plaque, the seeds, and the optic nerve sheath that appeared in my paper on slotted plaques. And it's important to note that the slot doesn't have any seeds in it. And that's one of the pieces of information that are very important. People might say, well, gee, you know, we have all this tumor in the slot. And sometimes for small juxtapapillary tumors, the entire tumor will be in the slot. But the gold of the plaque is not the radioactive portion, it's the seeds. So as long as you put seeds in a correct distribution around the slot, the radiation fills in the slot and creates the normal plaque distribution that circles the entire tumor plus a normal margin of tissue. This was one of the first cases, and here you see an actual slotted plaque with the cutout. And these are ultrasound imaging showing the plaque around the optic nerve, completely encircling it. And here another three-dimensional reconstruction of the tumor, the optic nerve, and the plaque being measured. As you see, ultrasound is really important for imaging of plaques once they've been placed on the eye. In terms of radiation source selection, the 2014 ABS guidelines that I had mentioned, those consensus guidelines, allowed people to use available sources, but they did suggest that we compare the dose distribution of each source that's available in our centers to normal ocular structures, like how much, if I use iodine, how much radiation is going to go to the fovea or the lens versus palladium if those are both available, or what is the relative dose distribution of a ruthenium plaque versus a palladium or an iodine if they're available. In general, properly handled with some experience, most of these sources can be used to kill the tumor, but they can be differentiated by their side effects. And the side effects are directly related to how much radiation will go to these critical structures. And if we don't measure the amounts of radiation to the structures, we won't be able to correlate the radiation side effect with the doses that are used. In terms of cost, palladium is probably the most expensive per seed versus iodine and ruthenium and strontium. However, there's other costs like radiation side effects, loss of vision, and subsequent treatments that are needed. And so sometimes people ask me, well, you know, those palladium seeds are more expensive than using ruthenium. We need to look not only at the cost of the treatment, but we need to look at the cost of vision loss and also the cost of treating secondary complications. So all radiation sources are not equal, but a comparison of each one is really not within the realm of what I can discuss during this talk. So in conclusion, there really is no need for iris resection or iridociliary resections. Plaque brachytherapy has huge advantages. We get to keep our normal iris. You get to keep the function of, most patients get to keep the function of their pupil. The local control rates are as good or better than local resection, and you don't have the risk of intraocular surgery. There's also no need for enucleation for most patients. Patients who have tumors who are wrapped around the optic nerve can be treated with slotted plaques. Even large or extra large tumors can often be treated. When tumors get quite large, those are the ones that sometimes come to enucleation or removal of the eye, but even those sometimes can be spared as long as the patient understands they may lose their vision. However, there needs to be a multi-center comparison of all these radiation techniques. We are starting a thing called the Radiation Side Effects Registry. It's a prospective registry where we're collecting all of what happens to patients after they're treated with these various forms of radiation. Hopefully, in several years, we'll have the information that'll help us differentiate which types of radiation may be best for each tumor and tumor location. Thank you.
I want to take a moment to thank you for your attention, and to thank the Eye Cancer Foundation, who supported much of the research presented in this lecture, and for their committed support for international multi-center cooperation in ophthalmic oncology. Thank you and have a nice day.